Good afternoon, everyone. My name is Tony Mancuso, and I lead communication efforts for the Summer Health Professions Education Program, better known as SHPEP. For those of you who are unaware, SHPEP is a free 6-week summer enrichment program for college freshmen and sophomore students who are interested in the health professions. To learn more, please visit shpep.org. And with that, welcome to Diversity Session 1, Dispelling the Myths of Admissions. As you know, the SHPEP National Program Office recognizes that increasing diversity in the health professions is a collaborative effort that pre-health advisors spearhead at the undergraduate level. Ultimately, you have the critical role in guiding students on their path to the health professions. After assessing the needs of pre-health advisors, the SHPEP National Program Office has partnered with the AAMC's Action Collaborative for Black Men in Medicine to annually provide sessions that could positively impact the way you advise students from underrepresented and marginalized communities. Here's a few housekeeping items for today's session. Please use the Q&A feature to ask any questions during the webinar. You are more than welcome to use the chat feature to give advice or react if something resonates with you, but questions should be submitted through the Q&A feature. And as always, SHPEP webinars are posted on our YouTube channel within a week of the live viewing. I'll now turn it over to Kim Bellamy to give us a few brief words.
Good afternoon, everyone. My name is Kim Bellamy, and I serve as Lead Strategic Programs and Partnerships within Equity, Diversity, and Inclusion at the AAMC. I'm also a member of the organizing committee of the Action Collaborative for Black Men in Medicine, which you all see as part of our joint initiative for this webinar here today. So I want to provide some context on how the topic today connects to this initiative. The Action Collaborative for Black Men in Medicine is a co-sponsored initiative between the National Medical Association and the AAMC. The two entities came together in August of 2020 to address the underrepresentation of Black men they've noticed over the course of several decades. When we're thinking about advancing diversity within the physician workforce, Black men are definitely a population that have been noted as an area that we can pay more attention to. Particularly with the landmark report Altering the Course, it was highlighted that there were more Black men applying and matriculating into medical school in the 1970s than there were in 2014 when the report was released. So as a result, the Action Collaborative came together to begin identifying what are some of the systems factors that are influencing the trajectory of Black men entering the profession. We looked at this at 3 different lenses, including what are the pre-med systems factors, what are the academic medicine system factors, and what are the socio-cultural system factors. Within the pre-med systems factors, you all as pre-health advisors was a key area in which we felt like we could definitely influence and provide more support, hence why we are hosting this webinar today. In terms of academic medicine systems factors, medical school admissions was another area in which the group said that we needed to pay more attention to make sure that we saw more of an increase in the number of Black men going into the profession. So as a result, today you will hear from 2 of our steering board members of the Action Collaborative who also work directly within medical school admissions that will help you determine how to best support this particular population. I will now turn it over to our 2 presenters today, Dr. Alden Landry and Dr. Steven Starks.
Thank you for the introduction, Kim and Tony, and thank you for pulling this presentation together. We're excited to be here. I think both Dr. Starks and I can just do some brief introductions. And so I'll go first. So again, Alden Landry, I'm an emergency medicine physician. I practice at Beth Israel Deaconess Medical Center. I also serve as the Assistant Dean for the Office for Diversity, Inclusion, and Community Partnership at Harvard Medical School. I think more importantly, and really how this fits within who I am and where I am a product of the program that we're discussing, the Summer Health Professions Education Program. Though by my age, I did this program many, many moons ago when it had a different name, called the Minority Medical Education Program. And I learned of the program during my time when I was at Prairie View A&M University for my undergrad education. This program has truly been a transformative experience and has helped me to really become the person I am today, and helps shape some of the decisions that I make from a career perspective, and then also encourages me to continue to give back to a program that really contributed so much to my professional growth and development as to where I am today. Dr. Starks.
Good afternoon, everybody. I'm Stephen Starks. I'm a geriatric psychiatrist and clinical assistant professor at the Tillman J. Fertitta Family College of Medicine, where I serve as chair of our admissions committee, assist our colleges with community partnerships and curriculum development, and serve as our psychiatry clerkship director. I, unlike Dr. Landry, did not have an opportunity to participate in this program, but wish I had. So we hope that we get a lot out of today's session, and we do appreciate your engagement today. I'll turn it back over to you, Alden.
Thank you, Stephen. All right, so what we're going to do is just have a quick conversation to really set the stage about where we are at when it comes to workforce diversity in medicine, and really starting back and looking at the matriculant data for those who are accepted to medical school. And I think this is a helpful snapshot for you all to understand where we're at and why we're having this discussion. But I want to take a step back and even further and talk about what Kim was mentioning with the Action Collaborative and the conversation that was happening from the AAMC with their report on the lack of Black men applying to and entering into medical school. And we often refer back to that data in 1978, that there were more Black men who were applying to medical school than there were in 2014. And subsequently, more Black men accepted to medical school and in 1978 compared to 2014. But I think what you have to understand in that report is what has happened, and it's sort of evident in the bottom of the screen, which most people don't really pay attention to, is that you can see for the total matriculant numbers, just in general, that each year the size of medical schools by and large has grown. And so what that means is, despite the fact that we had growing sizes of medical school classes, where schools that may have had 80 seats now have 100 seats. We also had the growth in the number of medical schools in general, meaning that there were more medical schools in 2014 than there were in 1978. So when we look at this number and we see that there was a decrease, we have to understand that the denominator makes this number even more dramatic. And I also want to take an even step further back and reflect on an effort that was pushed by the AAMC and Dr. Nickens, which was 3,000 by 2,000. And the goal of 3,000 by 2,000 was to have 3,000 underrepresented students, or the definition they were using at the time was underrepresented minorities, accepted to medical school by 2,000. And unfortunately, we didn't get there by 2000. And that was even a journey for us in academic medicine, or the admission side, to get to there. And I believe it was around 2006 or 2007 that we realized Dr. Nickens' goal of 3,000 by 2,000. And so I say all that to put this in the context as, this is not a problem that just popped up, within the past 5 years or 10 years. This is something that the AAMC has recognized as part of their work and has been trying to address. But unfortunately, there's been a number of barriers along the way that have prevented us to getting to where we want to be. Next slide, please. So here, this really focuses in on an issue that we're seeing specifically when it comes to gender workforce diversity issues by race and ethnicity. So medical school has actually become it was, I believe, in 2018 or 19, when we started to see more entering classes that were majority women than men. But when you break those numbers down for women and men, you see that there are some pretty drastic issues that are happening when it comes to the total number of students entering into medical school and graduating from medical school. And you can see that these numbers for Black men are relatively small, meaning 3,000 Black men out of a total of 44,000 male medical students. Also highlighted are Hispanic or Latinx students of 3,200, also a small number. But also I want you to just recognize that the overall trend has not been towards this, large growth in numbers. It's been relatively small incremental numbers. Again, taking into account that, the number of men entering into medical school has gone down, but the size of medical school classes and the number of seats have gone up. Next slide. And this, again, just encapsulates everything that we've been talking about thus far. We had, when the report came out in 2016, 2017, from the AAMC, there was a fervor and an interest on really addressing the number of Black male applicants and matriculants to medical school. And we did see a boost in the numbers, and as evident by what happened in 2020, where we got higher compared to 1978. And last year we did, well, I guess now 2 years ago, we did really quite well in seeing that growth in the number of Black male matriculants. But as you can see, we're starting to recede back from that. And I know there was a big conversation around medicine as a career that was something that people would aspire to go into, especially with COVID and all the issues that we're hearing about our healthcare system. But I, again, just want to make sure that we all understand that even these, we may be seeing a blip in a radar with that 2021 number. As we go back down towards this baseline, we need to make sure we're not trending down, any going below. We also need to recognize the fact that not only did COVID have this, they called it the Fauci effect, where more people were interested in applying to medical school for a period of time. But we're also seeing the ramifications of what happened during the pandemic, where students were away from their schools, and we saw numbers of enrollments overall for students to maybe go down in certain demographic groups than others. And I think this is something that we have to keep a close eye on and continue to trend out this data, understanding that students who have community colleges on their transcript and may have used that time for, that transition time between high school and college. Well, in the next 3 to 4 years, those may be the individuals who would be applying to medical school, but may not. So just again, this is, sort of setting the stage and recognizing that we need to be proactive in this space and understanding that these trends may go in the wrong direction as we still deal with the ramifications of the COVID pandemic. Next slide.
All righty, and I'll take over here after Dr. Landry's great introduction there. And just a reminder, and to something Ms. Bellamy alluded to earlier, is that the Action Collaborative is looking toward collective impact, and we're really trying to kind of figure out and understand what all the stakeholders, all the players' roles are in addressing some of these gaps. What I'm going to do now for you is just present to you some preliminary data from a survey of pre-health advisors and medical students to set the foundation for our discussion today. So the aim and objective of that survey was to understand the experiences of pre-health advisors as it relates to training received that's focused on medical student applications, that's focused on knowledge and insights about medical school pathways, and also to understand the preparation that you receive in terms of advising students who are from backgrounds that are underrepresented in medicine. And then the outreach for this survey was through newsletters, listservs to gauge and garner engagement. And here are the results of that survey. So just a quick snapshot, a little bit about the demography. So 73 respondents in total. Most of those were white, so 80%, and most of those were women, 80% nearly as well. And that's pretty consistent actually with what we know the figures in advising are, and actually a little bit different than the registrations for this particular event today. So in our group today, we have about 60% of individuals responded that they were white and about 73% women. So there might be some little bit of selection bias there. Again, you may have registered for this program because you may have been obviously interested in the content that we're delivering today. And a little bit in terms of preparation or feeling prepared for medical, pre-medical advising. So the method of learning that most advisors stated that they had were webinars from NAAHP, onboarding by a peer at your institution, but you'll see a large number, 56% were self-taught. About half of the group, again, engaged in some education through AAMC webinars and other resources, and then some from prior health professions experiences or from their previous employment. The method of learning and whether or not those particular methods of learning were useful and fully preparing advisors to support URiM students. You'll see that about half responded yes, but again, half responded no. And whether or not the methods of learning fully prepare them for addressing all aspects of the medical student application process. Again, 51% said no. And then overall, in terms of advisors, their own knowledge assessment, the top 5 topics that there was a desire for more support for were funding and financing. So how do students, or how do you help students find funding and financing for the application process, access to summer enrichment programs, how you connect them with opportunities for clinical experiences and research experiences. MCAT prep was a large part of that, and just basically an understanding about the admissions processes. So how do admissions committee operate in terms of their review of applications and holistic reviews. The same, we surveyed students again to understand their access to information about medical school pathways from Prehealth advisors and similar types of outreach through newsletters and listservs. Here is a snapshot of our medical student demographics. So a total of 239 respondents. Again, in terms of race and ethnicity, students were able to choose multiple identities. You'll see listed here that we have about 42% African-American, 33% Hispanic, and in terms of gender, we have 66% of that group being women. And the questions we asked them were in line with their access to pre-medical advising. So do you work with a pre-health advisor? 56% said yes. And the top reasons for those students who didn't have access to pre-med advising or didn't use a pre-health advisor were here on the top right. So pre-health advising was unavailable at the institution. Some had previous negative advising experiences. Some have not identified an advisor or are just unsure how to identify an advisor. Many do self-advising. Some are non-traditional students. Some are not currently enrolled in school, therefore have difficulty with access. And then a couple didn't meet criteria for advising. And their top sources for guidance for the pre-medical pathways are listed below. So many use websites and online tools, which is customary for this generation. A lot do self-advising, only 40% with pre-health advising, and then 40% have some sort of mentor or role model to guide them along the path. And they also had a desire for support. In the top items listed, you can see they're all clustered pretty closely. Students could choose multiple options, but wanted to learn a little bit more about admissions criteria and school options, financing and funding, opportunities for clinical and research experiences, application process and timeline, and MCAT prep. And you can see 4 out of those 5 were consistent with the responses from the survey of pre-health advisors. And then other topics identified in terms of students wanting and needing and desiring more support were mentorship, institutional or AAMC support, access to resources, peer support, and of course, finances there. And then in terms of the barriers to working with pre-health advisors, just a little bit more of an understanding. There was, in many cases, limited access to advisors. Some were ineligible based on their major or based on institutional guidelines. Many just had a lack of pre-medical pathways. Some were discouraged to pursue medicine due to their academic profile, or discouraged to pursue medicine due to their extracurricular or engagement in student athletics. And then many just felt that they had an inability to connect with an advisor on a personal level. And in terms of their comparison of their support compared to the support of other students, the question was posed, do you have the same opportunities and or level of support as other pre-medical students at your institution? About 54% said yes, and about 26% said no. And if they said no, many of them kind of cited issues related to access, being a non-traditional student, or financial barriers. Few did note that they thought it may be related to their race or ethnicity or some other personal aspect. And so just to summarize those findings quickly, pre-health advisors, again, have a large pre-medical advising load. I know we're preaching to the choir, and then not many students from backgrounds that are underrepresented in medicine. There was a lack of formal training that again was noted, and then pre-health advisors noted that their strong support is needed to increase their confidence about advising on finances and funding. And then for pre-medical students, advisors aren't always the first source that they seek for guidance on pre-medical pathways. Access was noted as a consistent barrier, and there was a common theme about a lack of trust or the inability to form a connection with advisors. And so what we'll try to do today is kind of address some of the myths about the admissions process. We'll try to let you in behind the veil here to get some insights from both of our experiences serving on admissions committee. But we did want to frame that from based on your questions. And so we appreciate you all leaving questions or comments. Here is just a summary of some of the content that you all were hoping that you would receive today that we hope to cover. And again, if you have more questions, please use the Q&A, and I hope that you're engaging in our chat. I order these in just terms of the number of those common themes from our about 120 responses. And many just wanted to learn a little bit more about working with kind of URiM students. So really understanding kind of how to best engage and reach with a student, how they could address maybe some of the vulnerabilities that students from those backgrounds face, and engaging with pre-health advisors. And also wanted to understand the concepts of competitiveness. So what does that mean, particularly as it pertains to URiM students and other students? Best practices, just a question about fit, who's fit or unfit, based on some kind of stereotypes about what the cookie cutter medical student looks like. You wanted to learn a little bit more about non-traditional classifications, obviously finances, and how do you kind of assess and help out your students who may be from disadvantaged backgrounds. Questions about how students might or should, whether or not they should express their identities in applications. And again, other components of the application process itself. So what types of experience they need, questions about personal statements and how to compose those. And of course, how we admissions committees view letters of recommendation and committee letters. I'll stop sharing my screen here, and Dr. Landry and I will just kind of have a conversation about those topics there. I actually wanted to start, Dr. Landry, but maybe asking you a little bit about your pre-health advising engagement when you were a pre-med student at Prairie View A&M. How did you engage? What did that look like for you? And then maybe share a little bit of insights now that you're on the other side. So now that you have had very strong work in leadership and diversifying the workforce and diversifying your medical college.
Yeah, thank you for that. And Stephen, it was really interesting just to hear sort of the discussion that you were having and going through sort of the struggles that pre-health advisors are dealing with, and you juxtapose that to some of the concerns that pre-medical students are dealing with as they are on this journey, because I think there's some overlay that will be really helpful for us to have as part of this discussion. And you mentioned sort of cookie cutter medical applicants in medical school. And when you said that term, I sort of got a shiver down my spine, because I think I actually was, to a degree, a cookie cutter applicant to medical school. But now I'm in a position to see that maybe the cookie cutter applicant to medical school isn't the best applicant to medical school. And I say that looking at my own sort of journey and pathway and thinking about the totality of my experience and to where I am today as a practicing physician. So just to give you a little bit more context, I graduated from high school, and my intention going in was to be a biology major with the understanding that that would put me in the best position to apply for medical school. I was fortunate to go to a high school that offered a number of AP courses, and I was able to bring that to my transcript to college, which helped me to be in the best position to go through college relatively quickly and eliminate some of the courses that were non-science courses that I needed to have as part of my graduation from college. And I also did summer programs along the way, including MMEP, now SHPEP. And so from that perspective, I was very much a cookie cutter student. And I also look back and I think about the relationship I had with my pre-health advisor. And I want to couch this in understanding that and the HBCU experience for students is very different than other institutions, especially smaller HBCUs like the school I went to, where we had direct relationships with our pre-health advisors because they were also the science teachers in the Department of Biology, Department of Chemistry. And so when you're not only taking courses from those individuals, but also being advised by them, it leads to a different relationship than someone who is just your pre-health advisor in this aspect, and then someone who is teaching you biology, genetics, organic chemistry, embryology, et cetera. And so to have that sort of, I don't want to say, to have that individual serving in one or multiple roles in the development of a student leads to a different relationship. And I would say that closeness was actually beneficial to me because I'm someone who establishes relationships quickly. Plus, I was performing well in school, so it made for even better relationships in the class, in the discussions around career advising. I would say for some of my classmates who were quote unquote late bloomers in their first year or two of college, they weren't as successful, but by the time they got to third and fourth year of undergrad and they were doing much better from an academic standpoint, because of that model, they didn't necessarily have that same type of relationship that I did with the pre-health advisors, because the pre-health advisors saw them when they were struggling, and then saw them as when they started to do better, but still had reservations because those assessments of those individuals were sort of created early on. And unfortunately for some of those individuals, some of those students, those reputations were, carved in stone, even though the student had made that trajectory in the positive direction that you would anticipate a student to do so as they came into themselves in college. So that was my experience in college. And I just wanted to give sort of the two sides to at least my experience at a smaller institution. Now that I'm on the other side and I think about this whole cookie cutter applicant to medical school, I think, especially as I think about what we want from our students, and more importantly, where we expect our students to go back to, we have to move away from what that example of a cookie cutter student is. Because there's data that shows that students coming from, a diverse medical student experience background, meaning they have, classmates who are non-science, classmates, are students that come from more diverse backgrounds when it comes from race, ethnicity, or sexual orientation and gender identity. When you bring all of that diversity into the classroom, it actually leads for better outcomes for those students, and those students feel more prepared to be to care for diverse patient populations. And we have to remember all of this goes back to who these people are going to be caring for once they finish medical school. Once they finish medical school, transition to residency, we are creating doctors, and we need these individuals to be comfortable in caring for a diverse patient population. And so we have to have more diversity within who we accept into medical school and who we accept into the specialties and subspecialties of medicine. And so as I hear the conversations now around the table, when I'm in admitting conversations where we're talking about comparing candidates, sort of looking at transcripts, looking at academic portfolios, looking at lived experience, more conversations are now happening that are straying away from MCAT and GPA and really talking about the totality or the lived experience of the individual. And so as you are advising students, please recognize that those diversity aspects that historically have been a negative are actually becoming more and more, I don't want to say appreciated, but more and more considered for those students when they're applying to medical school. And I'll talk a little bit more about what I mean in that as we get through some of these other points. But again, I'm just going to pause here and turn it over to Stephen and let him take a stab at that same question.
Yeah, great. And what I appreciate is that we are somewhat opposite, a lot, just obviously in terms of some of our work, obviously similar in a lot of means too. But I attended a predominantly white institution, the University of Houston. So it's interesting for me to have been a confused pre-med many moons ago, and now to return as founding faculty to our brand new medical college. But for me, the path was much more difficult. So was a kind of pre-med major when I started, biology major, biomedical engineering major actually when I first started college, but just didn't have the same level of focus on that path, right? So I had a very good time my first year of college, maybe too good of time, and felt like I struggled really after that failure to kind of reestablish kind of a clear path toward medicine. So although I continue to be a pre-med, changed my major to psychology, again, something that was much more aligned with my interest at the time, but still struggle with the pre-med courses. And that kind of persisted throughout my 4 years at my undergraduate institution. And so for me, it was after graduation that I like your term late bloomer. I guess would consider myself to be the same way, as kind of when I had renewed focus. But for me, it was thinking about, well, how do I get over these successes? So how do I get over having a sub 3.0 GPA? Is there still an opportunity for me to get on the path to medicine? And I remember distinctly approaching trying to engage in pre-health advising after graduation, and quickly got the message or the signals that you are not that cookie cutter fit, so to speak. So for me, I retracted from seeking out more advising because I didn't think that would be useful. And so I used some of the measures that students today are outlining. So for me, it was student doctor network. It was learning as much as I could through the internet. It was talking to admissions committees and figuring out, okay, what do I need to get on that path, and really kind of doing it on my own to kind of figure out the path towards success there. And so I think I wanted to share a part of that because I think it's important for advisors to really think about the signals that you're sending and the messages you're sending to students. I think there were some comments in terms of some of the comments and questions submitted that kind of pointed to that, right? So how do you create a safe space for students who may feel vulnerable because they've had some hiccups in terms of their academic path, and how can you support them in the same manner that you would support a student who has strong academic strengths through their GPA or MCAT success. So one thing I wanted to frame that. And then now being on the other side, to your point, it's also thinking about how we look at and monitor these holistic reviews. So my medical college is focused on increasing diverse representation in medicine. It's focused on community engagement. And so we're very involved in trying to connect with local community partners in historically excluded groups. So our local third world community here in Houston, which is predominantly African-American, and our historically Hispanic community, Houston's East End. And so we would like students to come from those neighborhoods. And we do oftentimes have to think a little bit more broadly about experiences and activities that students who may be first generation or may come from historically excluded groups identify. And that was one of the questions that I'll ask you. How do you look at and engage student experiences? So whether it's their experiences academically or whether it's their extracurricular leadership experience, research experiences, what are you looking for? Is there a cookie cutter matriculant at your medical college?
So I'll put this in the context of each medical school is different, and what we are seeing at the trends at my medical school may be vastly different than what may be happening at your institution. I think we have to recognize that not all medical schools are the same, and hopefully that their admissions process are rooted in the mission and vision of the institution. And so as you look at and you talk to students about how to encourage them to apply to medical schools, I think part of that has to be about which schools fit the mission and vision and values of the student when they are reviewing the medical schools that they're going to be applying to in the hospitals and the communities that they serve. I think it's important for us to understand that a lot of students come into this with the mentality that they have to do all the check boxes to get into medical school. They have to check off the box of, I not only was in a pre-med club, but I held leadership. Not only did I do community service, but I volunteered X number of hours. I shadowed this number of physicians and did this number of physician hours. I did summer programs, I did research, et cetera, et cetera, et cetera, to the point where students start to stray away from truly doing the things that define them as an individual to doing things that they think will meet a mark to get into medical school. And what I instead try and do when I talk to students, especially as I look at those who have gotten into my medical school and that I've been engaging with students over this longer period of time, is the students are going to be most successful are the ones who find their path and their passion early. And what I mean by that is if you are not someone who is vested in research, then maybe doing that experience at that time is not what's best for you. And this is where I actually stray from that cookie cutter model. I actually did not do research when I was applying to medical school, because at that time, that was not something that I felt was of interest to me as far as my career growth. But what I did was I supplemented that with other activities and other experiences that helped to round out my application. And I always tell medical students, applying to medical school is like trying to put together a puzzle without exactly knowing what it's supposed to look like. But you take the pieces that you have, you put that into the prettiest picture that you can do, and then that's what you submit to the application, to the admissions committee at the medical school. So you take the pieces of your life that you think represent why you would be best fit for medical school, and that's what you present in the form of your application and your personal statement to applying to medical school. For me, the things that I valued was community service. The things that I valued was leadership, in particular in helping to shape some of the issues related to health and health equity. At that time, we were still talking about health disparities, but at that, having that conversation at an early stage, because that mattered to me, discussing health disparities, being a leader when it comes to having conversations around even then workforce diversity. And so this is something that I've been passionate about since I got into medical school, since I got into undergrad, and has been my passion and my driver, one of the driving forces for me going to and through medical school and to where I'm at in my career. And I made sure that as I presented that as one of the driving issues for me, I put that as a part of my application early on and helped to have those things that went along in parallel with that, with leadership and student organizations focusing on increasing the number of Black students applying and matriculating into health profession schools. And I say all of that to say, when I look at the students who are being accepted into medical school now, do we have cookie cutter medical students? Obviously, yes, that has not changed. But do we have students who are coming in with unique backgrounds or experiences that are helping them to get to a place where they are going to also add value to medical school? Absolutely. Some of these students are coming to it from a business model because they have prior experience either in consulting or business management, or they had experience in the real world working in business before making that transition to medical school. Other students are coming at it from an educator's perspective. We have many students who, after finishing college, have gone on to do teaching opportunities such as Teach for America. We have other students that have gone different directions, such as doing Peace Corps, or even just taking time to have a regular job and during that time to build up their skill set so that they can be ready to apply for medical school. So with all of that, I think it's important to understand that, there are changing demographics of who's being accepted to medical school. I think the average age for students getting accepted to medical school is 25. So that means that those students who are graduating college at the age of 22 and starting medical school right away, that's becoming less and less of something that's common. And I think we as Prehealth advisors, we have people who are advising or mentoring medical undergraduate students as they pursue careers in medicine. We can't close that door for those students who are like Dr. Starks, who are those late bloomers, and that first year or two of college was a lot of fun and there was a lot of growth that was happening. And then during the maturation process, become better adept and prepared to focus on their education and be in that next position to apply to medical school. So maybe I'll pause there and turn it back over to you, Steve.
Sounds good. And I'll answer one of the questions that had come through the chat that kind of alluded to your point is, so what steps did I take to become competitive for medical school? So first thing is first, because there are others who inquired about this, is how do you engage students who may have trouble with their academics or not have access to certain experiences? How do you advise a student who does not seem on the surface competitive? And one, I think it's important for you to maybe encourage that student to have a realistic appraisal of what they need to do in order to get there. And so if it's a problem in terms of their academics, obviously they may need to do some additional academic program or master's program. So for myself, first it was focus. It was kind of a little bit of bootstraps. And so I picked up those textbooks that I had never read before and went through all of them as I studied and prepared to take the MCAT for the first time. So for me, I thought, I could still get it if I just, use these same undergraduate GPA and science GPA, take the MCAT, be successful enough, I could apply to it. And I did that the first go round and was unsuccessful. So got those 10 rejection letters at places that I would never have been competitive enough to get into. But that just helped me to kind of refocus. And what I'd say is most important for you to encourage your students is about to understand their mindset. So there were two mantras that I tended to go over and over in my mind. It was one, don't let the odds intimidate you, because everything suggested at that time that you'd never get in with your kind of current application, you never get into medical college. So that was one. And the other was that you don't have to believe in my dream. So to all the world, the naysayers who said it wasn't possible, those were the two things that stuck with me. And for me, it was, again, figuring out how do I get there. So it was talking to those chairs of the admissions committee or admissions committee members who rejected me, getting some insights on what I needed to get into their medical college. And I remember distinctly at LSU School of Medicine in New Orleans, I spoke with the admissions chair, and he mentioned that, you know, everything else is fair. Your NCAT is fair. You just need to do some advanced science courses and kind of reapply. So I did that and more, right? So did my own kind of informal post-bac program at the institution that I graduated from, started to volunteer. As a result of starting to volunteer, started to get some leadership opportunities and volunteering, and really was very kind of community engaged and a mentor, invited to be a part of a volunteer board of directors, was too kind of gun shy to apply immediately after that first rejection. So waited and took my time and paced myself, which is, I think, is also kind of good advice for some students. And so I'd done so much more, reapplied, and then ultimately waitlisted at that school again, but later accepted. So again, did come with some challenges, and then a more realistic evaluation and appraisal of these colleges that I actually applied for. So as Dr. Landry talked about, every medical school is different. So the more than 150 medical schools in our country have different missions, different aims. Students should do some research, and you can help them maybe starting with your state institutions, right, to get an understanding about what is the difference between those programs, and helping students to do the same. You want to make sure that it is an appropriate fit. So if you want to go into a specialty and you're applying to a school that's focused on primary care, that might not be the best fit in terms of the information. Another question that has come about in the chat and also in some of the pre-sent questions was about how, if there's a racial or ethnic discordance. So if you're not from a background of a URiM student, how can you best establish a trusting relationship? And I think it starts off with listening first. And really, I think it may, in some instances, take a little bit more time to engage those students to understand, you know, their experiences, their background. And I'll also say, because it was also listed, is that you're maybe not seeing a lot of students come into your offices, right? They're out on campus somewhere, but you can't, you aren't able to engage them in the traditional means. And so I would ask if it's easier for you to go to them, right? So to go where students might be, to join some of those student organizations, visit with those student organizations, even if they're not the health professions or medical related student organizations. Perhaps you could go to the Black Student Union or the Hispanic Student Union to kind of share some of your insights and ideas, or to talk a little bit about the services that you offer as a part of your advising office. I think it's also important when you're trying to build and establish trust, is just to maybe kind of think a little bit about your understanding about the communities that you serve. So you know the demography of the students at your respective institutions, but do you also know the communities nearby, right? Do you know the neighborhoods that your students may be coming from, or engage in that in any way? Again, I think trying to connect and understand the backgrounds and experiences of your students will help build that trust. And again, I think you may have to think a little bit outside of the box. And it's not easy, because I know how busy you all are with your work. I know how difficult it is with the workload that you currently have, but maybe thinking about interesting ways of connecting through social media, or again, through seeing students where they are. Any recommendations from your perspective, Dr. Landry, on how advisors can establish trust?
Yeah, I think you hit the nail on the head with sort of getting outside the office. I think that's a big barrier to a lot of students, whether it be the intimidation factor that comes with scheduling appointment, or even just the accessibility aspect that students often refer to with, not able to meet up with a pre-health advisor at a specific time or a specific location. And so when pre-health advisors step outside that box and come to the students, either meet the students at their student organization, or they go to the club meeting and answer questions, or they're interactive with the students, that helps to build those relationships. I also have to just stress the fact that these, students may only be at your campus for, 4 years. However, the reputation that you develop early on with those students can unfortunately be very long lasting, or fortunately can be very long lasting. And so when you have strong relationships very early on with students and you build that trust and rapport, that information is going to be shared, because oftentimes the juniors are talking to the sophomores and freshmen and telling them, yes, you can go and trust, this person, or be cautious about engaging with this person, because word of mouth will spread. So as you have those positive interactions with those students, hopefully you will have built-in trust, because others are going to go back and spread the word about how you made them feel when it comes to helping them to feel comfortable overall about their experiences. I think also, this is a great time and opportunity for us to engage in even these types of interactions that we're having here with webinars and social media. I know that I have been asked to come to speak a number of pre-health clubs virtually, and it's a great experience for me because it makes me feel a little bit youthful, but also it helps me it helps those pre-health advisors forgive me for using the term, build up a little bit of street cred, because they bring someone like myself into their institution, and they see that the students will see that their pre-health advisor cares, because they're being outgoing and engaging the community, and someone who may look like them, and bringing them in to talk to students about careers, health professions. And to be honest with you, a lot of the times when I go out and give talks, I'm giving the exact same conversations, exact same piece of advice that you all may be giving. But it's like hearing advice from mom and dad versus hearing it from your aunt or uncle, right? You may not want to accept it when you hear it from mom or dad, but when your cool aunt or uncle, and I'm giving myself the cool factor here, gives that piece of advice, it actually comes off a little bit different. So I would encourage you to think about who you can use as your allies to get these students engaged and to get them excited about to pursuing their careers in the health professions. And I saw a question that I wanted to try and jump in on, and I'll sort of skip to the heart of the question is, more students are taking gap years. When you're at smaller institutions, it's harder to engage those students. And so how do you recommend, what mechanisms do you recommend to engage students? And so for this, I really think it's, again, important to recognize that social media and virtual interactions are a tool that we should be using. And I know a lot of schools have turned from individual one-on-one mentoring to peer mentoring or peer advising and group advising. And this is a time, especially with those students who have stepped away from campus, whether they've graduated or they've taken some time away from college because they had other financial matters to address and they plan on coming back. That doesn't mean the advising needs to stop, but the advising should stop. And so it's important for us to think about sort of non-traditional ways to engage students. There's plenty of information that's going to be out there for students, but I think once they have a relationship with you as a pre-health advisor, there's ways to check in with students, whether it be through survey data, whether you have a pre-formed survey or quarterly virtual meetings that larger groups of individuals can join, whether it be for 30 minutes or an hour. And having those done at different times so that students who may have graduated and gone on to professional careers where 9-to-5 interactions aren't available, but having some off-hour opportunities is really important. And that allows you to continue to have that engagement for those students, because ultimately they're going to need those letters of recommendation. They're going to need that assistance with making sure their transcripts are in order. They're going to need all those other support mechanisms that come from undergraduate institutions and pre-health advisors, even if they're 2 or 3 years out of college. So think about ways to adopt technology as much as we're doing so with our interactions with patients. It's the same thing that we can be doing as pre-health advisors with engaging students.
We have a couple of questions here just in general about scores and numbers, right? Which people are always interested in. And again, the focus historically has leaned toward your GPA and your MCAT scores. AAMC has tried to move away from that, right? So the AAMC talks about the middle third, right? It was where medical schools should be kind of targeting, right? So again, you all know that the mean or average is 500. And so actually the scores around that are actually good. even the ones below it, right? Not above 500, but that whole middle third there of that distribution curve. And of course, also a question about GPAs. And again, we're always looking for positive trajectory if there were some hiccups earlier on in a person's kind of GPA, we obviously would be concerned, but if there's a positive trend with better performance in the more senior years or better performance in master's programs. But let's talk a little bit about the numbers themselves. How much do they matter specifically as medical schools are going through holistic reviews? Again, it is weighted in a sense, and I will share, at least for some medical colleges, that the admissions committees are actually blinded from the scores, right? So they don't see the discrete numbers there for the GPA or MCAT. There may be some pre-screening tool that's involved that may be a cutoff for an applicant to receive a secondary application. So they do come into play, but most times committee members don't have direct access to that. But Dr. Landry, how does it work? How are you evaluating a GPA and MCAT as it relates to admissions and kind of evaluating with other experiences and the totality of their personal statements and essays?
Yeah, and again, just couching this in the fact that at my institution there are 160 slots, and I believe there's almost 8,000 to 10,000 applications per year that come to our institution for 160 slots. So it's a very large number of individuals applying to our medical school. And I think you have to understand there has to be a way for institutions to quickly go through and look at and clear out some of the applicants that are not going to be qualified for medical school. And so some schools do rely still on MCAT and GPA. I think the reality is we have the number that we look at when it comes to what we will consider for further review is probably lower than a lot of what pre-health advisors are thinking. And I know most people think, oh, to get into my institution, to be at Harvard or any other Ivy League school, you need, that 3.8 GPA and you need that 520 excuse me, I'm switching exams to that 520 MCAT score. And that's not the reality. I think there's a lot more leeway on that. And I like the way that you reference that, Stephen, with sort of that middle third and looking at sort of where schools are, because I think schools are a lot more open to looking at students in that middle third, as long as the other components of the application are there. And so we really do try and do holistic review with each of these applicants and making sure that the totality of the application is reviewed. So letters of recommendation really matter. And those committee letters that you all are writing from your institutions really matter and help to share the story of the student. And I think this is a great opportunity for you all to think about when you're presenting a student and you're trying to give them the best foot forward. Oftentimes students want to shy away from some of the struggles that they may have, but this may be an opportunity for you to not only highlight the struggles that students have, but talk about how they overcame those struggles, because it helps us as an applicant, as we're reviewing applications, to understand where the student may be coming from. It may explain the hiccup that may have happened in a semester or two in college. And then it can help us to understand how this person was able to overcome any struggles that were before them. And we use the term resilience in medicine, and we maybe overuse the term, but I think this is a time when it's actually really helpful. It's growth and resilience as the individual overcame some struggles and got to a place where they were able to put together a stronger application. I also think this is a time for, especially in that letter of recommendation or those committee letters, to talk about sort of the entry into the academic journey that students may be coming into. As we talk about holistic review, we really want to focus on students who may be coming from that truly educationally disadvantaged background. Was their high school in a place that, had low graduation rates, or were there a large number of students that were on free or reduced lunch, which indicates some economic instability in the neighborhoods that they're coming from. And to see those individuals to come from those educational backgrounds, to be in a position where they're able to put together a coherent, competent, capable application in medical school, that actually helps us to see that distance travel that individual may have done. And so, yes, numbers are important, but not as important as we often stress them out to be. So for those students who have overcome some struggles, that have had an amazing distance travel and are in a position to apply for medical school. This is someone who you need to help craft that narrative so that we can see that picture. So yes, we may see a number, but we also know a little bit of the details that come behind the number.
Great points. And I'll just touch upon a couple of things as well, kind of based on some of the questions in the chat as it relates to it. So again, Dr. Landry mentioned that every medical colleges obviously uses their own kind of metrics and thresholds. And again, that's very variable. Again, I'll share for my institution and for other institutions too. Some medical colleges are looking at those numbers to help point and lend toward curricular success. Now, that's all we want. We want our folks who matriculate to graduate. And some schools set a bar differently. Some schools are actually open to helping folks graduate within 4 or 5 years. Not everybody is looking for that pace. And I always just remind applicants that oftentimes this is a marathon and not a sprint. And so when you are putting together your application packet, yes, if you have done the best that you can on with your GPAs, you've done your improved your grades throughout your undergraduate career, you've gone on to do some successful post-bac work, you've gone on to do your master's program, right? Again, with some success, you've done your best. Same thing with the MCAT. You've taken it, you've retaken it, you've hit your plateau on that number. There's no point in retaking those, but you do want to make sure that you are aware of your strengths, weaknesses, and limitations, and you do want to put the best foot forward with your total application. So Dr. Landry pointed to the importance of that personal statement and that narrative. So it needs to be thoughtful, it needs to be reflective, you need to maybe adequately kind of address some of the challenges that you face and how you overcame them. You do need some clear construction there. And so I myself, relatively good at writing, but sometimes people struggle. And even I struggled with this personal statement. Access to the writing lab or maybe connections with your office to your university or college's writing lab would be helpful for students who may have difficulty articulating that in written form. The same way in terms of your list of activities, again, make them robust. Dr. Landry already pointed to, you want to make sure it's something that's consistent and that you're connected to. You're not just doing activities to do a checkbox. And I think sometimes you do have to think about activities, particularly for students who are overburdened by employment or financial distress, or they're maybe primary caregivers of family members, right? Those experiences do count, and I don't think students are always aware of that. If you spent 3 years overseeing and intervening for the care of your grandfather after his stroke, that's also relevant, and that's actually relevant healthcare or health-related experiences. But again, if that's not articulated clearly in the application, we never know that. And the same thing in terms of committee letters and letters of recommendations. There were questions about whether or not they matter. They most certainly matter. And so you do want to ensure that you recommend that your students are asking their letter writers for strong letters of recommendations, that they're explaining to their letter writers, that they're applying to medical school and what that entails. And they may want to pull some information from websites to prepare and present to their letter writers so that they understand what medical colleges are looking for. If it's a specific committee letter too, again, your language matters. And so sometimes I've seen well-meaning committee letters that kind of knock down or take down the applicant a peg or two because of the way things are worded. And I do think you want to be sensitive to how those are constructed and ensuring that there is some depth to those letters of recommendation. And then also realize that committee letters come from various institutions, and some are very adept at it. So that letter that comes from Harvard may look a little bit different from the committee letters that comes from another state institution, right? So sometimes when you're comparing apples to apples, and we shouldn't, of course, do that, but it's only kind of normal in terms of biases, is you want to understand what the competitors out there are presenting for their applicants. And so just being sure that you know that landscape, I think is an important as an advisor or a member of a health professions advisory committee, so that you're putting your students on the best foot that they can be. And then I'll just shift here just in terms of cost, because we had a lot of questions about that. So sometimes take extra coursework that comes with more money, or MCAT prep comes with more money, or reapplying to medical school comes at a cost. And so, yes, I think you do want to have conversations with your students, with the folks that you're advising about the financial cost. So one, recognizing that there is an opportunity for them to be designated under a disadvantaged status, or to ask for fee waivers in the process. So AMCAS has fee waivers. Most medical colleges for their secondary applications may offer a fee waiver. I'm in Texas, and so we have a different application service, the Texas Medical and Dental School Application Service, that also offers a fee waiver. And so I think explaining and exploring that with some students, and I do think there's some resources on AAMC's website also about those who may be in financial distress there.
And I think just to go along with that, I think one of the things we have to encourage our students to do is think about not just using or attending community college as an entrance into a four-year institution, but also the ability to take some of their coursework at community college, especially for those non-major courses, as long as they're going to transfer to their college. That's something I took advantage of. The cost of undergraduate education is rapidly expanding community college costs while increasing or not increasing at the same rate. And so for some students, it is truly advantageous for them to go and take some of their non-science courses, either during the summer or they could take mini masters where they can get those same credits, but oftentimes at a cheaper cost. And so just helping the students to think about, what are the most fiscally responsible ways to approach this pursuit of a career in medicine. I would say, unfortunately, that no matter how much we talk about, the need to increase diversity within the healthcare workforce, one of the things that we're often going to be up against is the fact that 80% of students applying and entering into medical school come from the top 2 quintiles of family income. And so what that means is individuals with means are more likely to pursue a career that's going to be cost prohibitive to most. And so as we think about ways that we can sort of level the playing field and encourage students to apply to medicine, we have to think about, well, what free opportunities are out there? And for me, this program, SHPEP, was a huge push for me. It was a huge bonus for me because it provided me an insight into a medical school that I probably wouldn't have been thinking about when I was applying to medical school without having that experience of being there. It introduced me to some learning topics, skill building techniques to improve my studying. It introduced me to the MCAT and helped me to better understand what I was going to be dealing with when I was going to be in that phase of my journey towards medicine. And so I would encourage you to help your students find these programs such as SHPEP and others that are like it at local colleges. And I think most medical schools, if not all medical schools, both allopathic and osteopathic, have some form of programs to help students over the summer. Encourage those students to continue to take advantage of free resources that are available through the AAMC. My nonprofit, the Tour for Diversity in Medicine, we put out programming on a regular basis that's free for students, that offers that mentorship, that helps students to grow and be prepared for school. But ultimately, what it comes down to is cost. And I think one conversation I think is sort of happening in the background that we need to bring to the forefront is helping students to think about finances early and to be fiscally responsible when it comes to how they spend their money, saving for college, applying to medical school, applying for the MCAT, and I agree with Dr. Starks about taking advantage of the fee assistance programs that's available. That only works not only for students when they're applying to medical school, but also even taking the MCAT. And some of the organizations that are out there that have for sale products for MCAT preparation will also accept that fee acceptance program and use it as a waiver to give students discounted access to their materials. So that actually goes a long way for a lot of students. And we're not here to sort of push one particular service or another, but just think about that fee assistance program in that way. But then another conversation that we have to have, and I recognize that we're coming short on time, is the conversations that you have to empower your students to have with their families. Because as pre-medical students are going through this process, especially those who are historically underrepresented or excluded, those URiM students who are applying to medicine, more than likely they're first generation students for whatever reason, whether it be to go to college, to consider a career in the health professions, to be a pre-med student, whatever it may be. And oftentimes those students don't know how to have a conversation with their family on what this journey is going to look like, what the cost may be, how long it's going to take for them to get there, what are some of the potential pitfalls or struggles that they may face. And so early on, conversations that Prehealth, Premed advisors should be having with students is not only this is what my expectations are for you, this is how we can help set you up for most success, but these are the conversations that you need to be going back and having with your family, that you may be gone for the summer because you're doing a summer program, or you may not be able to work during the summer because you need to engage in a research experience. And it may be paid, but it may not pay as much as doing your regular job. Or you may have to save up money from a family standpoint in order to help that person to be ready to apply to medical school. And so they can start planning this out over 4 years as opposed to thinking about that 6-month crunch when the student says, I think I'm ready to apply. So empower your students to have these conversations with their families so their families can be better aware of what's going on and how they can support their learners just as much as you're trying to support them as a pre-health advisor. Their families can support them as their sons and daughters.
Absolutely. I think that's an important point because it actually made me think about, you talked about the financial currency that is obviously important in the process, but that social currency is also important as well. And so as advisors, having kind of more connections to that. So again, maybe thinking a little bit outside of the box and thinking about community supports that are available for students, either through community-based organizations, their families, local medical societies, with individuals from historically underrepresented groups. So they're Black or Hispanic, Latin medical societies that may be close by that, again, you can kind of bring in to offer you some assistance as you are directing students here as well. Trying to see if we can pull one more question before we turn it back over to our team here. So there were a couple of questions related to kind of when do you advise students to go maybe on another path outside of a career in medicine, maybe some other health profession, allied health profession. When would be a good time to tell them, okay, maybe pull back for now and maybe there's another path for you to still care for patients and community?
I love this question because I think we have to recognize that our job is not to be gatekeepers, but dream launchers. And we have to make sure that we aren't giving off a perception that we're telling a student, no, they can't. I mean, sometimes we really are. We're saying, no, you shouldn't, but as opposed to saying, no, you can't. But I think this harkens back to one of the earlier questions about building trust, right? And so if you have that relationship and if you establish that rapport with the student and you're able to have a conversation because you've known them since their freshman or sophomore year of college, you can say to that student, no, you're not ready. And these are the things that I would consider. But I would also encourage the students to get multiple points of feedback or advice, right? Because although they're hearing it from you, it may be helpful for them to hear it from other individuals who can help to sort of give them, keep them grounded and realistic. Stephen, you talked about going and speaking with somebody at a medical school and they look over your application after you're rejected and they gave you advice. And I think that's oftentimes helpful for students is to get feedback from other individuals. And you as a pre-health advisor can't take that personal. You should understand that it's important for students to get multiple pieces of feedback in order for them to make the best decision. But I also think we have to think about what is the message that we're trying to send to our students. And I think the reality is our students want to pursue a career in the health professions. And yes, they may say that they want to be a doctor, but oftentimes we don't know what the other options are when it comes to being a doctor. And so when you talk to a student and you say, have you considered a career in pharmacy or optometry or podiatry or dentistry or whatever else it may be, when you enter into that conversation with the student, you're not telling them you can't be an MD, you can't be a DO. You are entering into, have you explored this? You have an interest in, population health. Have you considered going into the School of Public Health? You have an interest in, thinking about this specific niche area. Well, did you know that pharmacists also do, epidemiology? Or did you know that dentistry, there's actually a track where you can do OMFS, where you can do facial surgeries and reconstructive surgeries, but you start off in dental school before you go back and do a surgical residency and do some time in medical school. And so when you give students an understanding of what the options are, and help them to see, well, this actually fits within the passion that you have, or this may actually be a better fit for you from your goals or interests, then instead of telling the students no, you're helping them understand what opportunities are out there.
Thank you, Tony. Back to you.
And thank you, Dr. Starks, and thank you, Dr. Landry, for such an amazing conversation today. You know, before we end today's session, I'm curious to hear, do you have any final pieces of advice for the pre-health advisors still on the call?
Yeah, I would say relationships matter, and having these interactions and sort of scripted, planned conversations with students very early on are important to start that relationship. But then be open and understanding that each journey of, each student's journey is going to be different. And your job is to not tell them where to go, but to walk with them on this journey.
Perfect. And again, I want to thank our panelists for helping to dispel some of the myths of admissions. For those of you who are inquiring, Diversity Session 2 will be held this fall and will feature the SHPEP Engaging Men Committee. And as always, SHPEP webinars are posted within a week of the live viewing on the SHPEP YouTube channel. Be sure to subscribe to our YouTube channel at SHPEP Connect and hit that notification bell to stay up to date with everything SHPEP. I hope you enjoy the rest of your day. Have a good one, everyone.